Welcome to Pediatric Sedation Anesthesia course. My name is Gary Badger, pediatric dentist and the professor of pediatric dentistry at the University of Texas School of Dentistry in Houston. I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. Section Overview. This section presents information to create an understanding of the continuum of sedation through which the dentist can make appropriate choices of pharmacologic agents that can be safely and effectively used for the various pediatric dental sedation procedures. This course is part of a 16-hour comprehensive program designed to meet the requirements of Texas State Board of Dental Examiners Rules 110.17, Sedation Anesthesia of Pediatric Patients. Today we're going to discuss Module 9, the perioperative complications and emergencies. Images used in this presentation are taken from non-copyrighted sources in electronic media and attributed as possible. The de-identified images are provided as an educational resource to illustrate techniques and procedures for clarity. The objectives of today's presentation: the candidate should be able to diagnose emergent sedation conditions, offer solutions to developing situations, and provide physiologic therapy solutions. Prevention of emergencies is really important. Knowing the baseline vitals of your patient and determining the overall health of the patient is the first step in preventing emergencies. Intercepting potential complications and collaborating with the primary care provider, the MD, the physician, to treat conditions that may influence sedation outcomes, or totally denying sedation will improve the outlook. The condition of the patient. The recognition of deviant conditions that place the patient at high risk for favorable outcomes allows one to intervene prior to the sedation day and thus precluding an undesirable outcome. It relieves the provider of decision temptations on the scheduled day, ensures the patient's time is valued, and reassures them you have the child's interest as the basis of your decisions. It appears that the youngest of children and those with complex medical histories appear to be at the greatest risk for death or permanent neurologic damage. Safe and appropriate dosing of overweight children and careful case selection are essential to favorable sedation outcomes. The administration of oral sedation medications is less predictable than IV to establish depth, and oversedation and respiratory obstruction can occur. Postoperative patient monitoring. A number of studies have implicated early release of postoperative patients before full recovery and has led to adverse sedation events. It appears that successful sedation relies on patient selection, safe sedation delivery, and adequate postoperative care for success. Pediatric sedation adverse events. The principal drug effects of the narcotic analgesics include analgesia, an increased likelihood of nausea and vomiting, respiratory depression, pupillary constriction or meiosis, depressed reflexes, including the cough reflex, orthostatic hypotension, urinary retention, and histamine release. Drug interactions of narcotics with antiemetic sedatives include increased sedation, decreased analgesic effectiveness, and an increase in the respiratory effect. Animal studies suggest that both narcotic analgesics and antiemetics can reduce the convulsive threshold of local anesthetics and increase their central nervous system depressant effects. Therefore, careful monitoring is imperative throughout the dental sedation procedures. In a case study by Dr. Moore, summary of adverse events for 14 cases were studied in 1973 and 1983. Looking at this diagram, we see on the left-hand side 4 green boxes. The green boxes indicate that these cases are reversible conditions. The red circles indicate that the patients had deceased or neurological damage. What it describes for us is the interaction between local anesthetics and sedative agents. And these agents, when they are not equal, tend to lead into a hyper-sedated methodology and can injure patients. This is the relationship between the narcotic, analgesic, and local anesthetic doses that produce toxicity. Dosage values are expressed as a percent of current maximum recommended dosages, and possible reactions are plotted as squares. Irreversible reactions are plotted as circles. The dosage appears additive. Irreversible reactions lead to death or brain damage and can be predictable when the maximum recommended dose does not equal the maximum recommended dose of the local anesthetic and have been exceeded by 300%. So it's important to understand that local anesthetic is a drug as well, and it has its own physiologic effects as well as the sedative agents, and adjustments must be carefully applied so that the amount of local anesthetic is not excessive, because it will add to the sedative effect. Moore recommends be prepared for emergencies, individualize drug dosage, and recognize and expect adverse drug effects. How does one, for example, manage laryngospasm? Well, first of all, one needs to stop the procedure. Stopping the procedure focuses your attention upon the laryngospasm, and really one must understand what has caused the laryngospasm. It could be the accumulation of fluids in the larynx. It could be the irritation of the drugs. It could be the effect of the drugs on the medulla and the sedation activities. So stop the procedure doing what you're doing. Call for help. Call 911. Let them know that you want to see them, see EMS, and have your assistant or someone close by run out to get the defibrillator. Administer oxygen 100% through a tight sealed bag valve mask and apply positive pressure volume to force the cords open. Use Larson's notch by applying inward and anterior pressure bilaterally while performing a jaw thrust. And prepare intubation equipment for potentially difficult airway. Deepen the sedation anesthesia using propofol at 0.5 milligrams per kilogram IV if you have an IV. If hypoxia persists despite deepening anesthesia, consider administering a paralytic such as succinylcholine or rocuronium at 1.5 milligrams per kilogram or 1.2 milligrams per kilogram, and then progress to intubation. Review of adverse sedation events like Cody and Pediatrics 2000. 118 cases were reviewed. 60 resulted in death or permanent neurologic injury. 28 had negative outcomes, often associated with overdose prescription or transcription errors. 39 overdoses in 34 patients. Negative outcomes associated with drug combinations and interaction. The use of 3 or more sedating medications compared to 1 or 2 was strongly associated with adverse outcomes, 18 of 20 versus 7 of 70. Nitrous oxide in combination with other drugs associated with adverse outcomes in 9 out of 10 patients. Adverse events occurred in spite of acceptable dose limits. Dental specialists had greatest frequency of negative outcomes using 3 or more medications. adverse events associated with administration by non-medical personnel, and drugs administered at home. We frown on the administration of drugs at home, and that has been discarded as a procedure in our current protocols. Death and injuries associated with the use of medications with long half-lives. Chica in 2012 reviewed adverse sedation events, and of the 17 claims that he reviewed, 13 sedations, 3 local anesthetic alone, 1 with general anesthesia. 53% or 9 involved patient death or permanent brain damage. The average patient age was 3.6 years of age. 6 by general dentist as anesthesia provided, and 2 involved local anesthetic alone or local anesthesia. Local anesthesia overdoses observed in 41%. The location was in dental office care. Of the 13 claims, only 1 office used physiologic monitors. The other thing to make a comment on this study shows us that 2 of the deaths were related or involved local anesthesia alone. We know now that there are maximum recommended dosages, and this is easily a preventable option when you prepare your sedation records in advance and calculate what the total maximum recommended dose is. It would easily avoid some of the deaths and neurologic damage that was occurred with these patients. The weight was not recorded in 1/3 of the cases, and we know that the weight is important for calculating our dosages of our sedation medication as well as for our local anesthetic drugs. And so these cases could easily have been avoided. Lack of monitoring is a significant factor. If you don't know the physiologic condition of your patient when you're working, it becomes a major factor and also could be avoided. Drug dosage is more influential than drug choice, producing adverse events. Remember at the beginning, and looking at other studies, knows that when you use 3 or more medications at the same time, it raises the risk factor. And so limiting your treatments to 1 or 2 drugs that is the lowest possible amount to achieve the effect that you want is the preventive activity of being able to do this. In the conclusions of this study, children that are less than 3 years of age or equal to 3 are at greatest risk during sedation and or administration of local anesthesia. Sedation in dental offices have a high chance of occurrence where care is being conducted. What are the effects of narcotics when they're used? Narcotics plus the local anesthetics are used in conjunction with each other, and it's important to know what the effects of narcotics are, as we know the effects of the local anesthesia, which we'll discuss a little bit more later. Nausea and vomiting is a very common side effect that can occur within the first few hours or days after surgery, and can be triggered by a number of factors, such as the medication, motion, and the type of surgery. Vomiting is the final part of a sequence of events coordinated by the emetic center located in the medulla. Once the patient leaves your office, nausea and vomiting can occur. The emetic center can be activated by afferent neural pathways from digestive, for example the pharynx, the stomach, or the small bowel, and non-digestive organs such as the heart, the testes. The chemoreceptor trigger zone, located in the area postrema on the floor of the fourth ventricle of the brain, containing dopamine and serotonin receptors and other CNS centers, for example the brainstem and vestibular system, report to us about the nausea and vomiting. How can we help this from happening? Treatment for post-op nausea and vomiting can occur with using Zofran, ondansetron, infants that are greater than 1 month of age and children that are less than 12 years of age. IV, less than 40 kilograms, 0.1 milligrams per kilo as a single dose over 2 to 5 minutes. If they're greater than 40 kilograms, 4 milligrams as a single dose over 2 to 5 minutes. This drug helps to control post-op nausea. Oral medication for nausea and vomiting is Zofran. It's an orally disintegrating tablet. Do not remove from the blister pack until needed. Peel the backing off the blister. Do not attempt to push the tablet through the foil. Using dry hands, place the tablet on the tongue and allow it to dissolve. Swallow with saliva. There's no need to administer liquids. It's a very easy drug to use, and typically many of our patients are greater than 40 kilos, and so a 4 milligram tablet would be easy for them to take. Oral liquid for nausea and vomiting. It is a clear, colorless to light yellow liquid with a characteristic strawberry odor. Contains 5 milligrams of ondansetron hydrochloride dihydrate, equivalent to 4 milligrams of ondansetron per 5 milliliters in amber glass bottles of 50 milliliters with child-resistant closures. Administer 5 milliliters 3 times a day, PRN nausea. So this, we have the tablets, and now we have the liquid that can control post-op nausea. Easy for patients that we treat of all ages. Ondansetron reduces the activity of the vagus nerve, which deactivates the vomiting center and also blocks serotonin receptors in the chemoreceptor trigger zone. Respiratory depression is the second cause of hypoxia in the immediate post-op period and can be due to residual effect of anesthetics, inadequate reversal, respiratory depression, airway obstruction, and laryngospasm. Airway obstruction may occur after the simulation of extubation is over. It can be diagnosed by paradoxical seesaw breathing patterns. The chest and the stomach in seesaw pattern results in intercostal indrawing of the subcostal and sternal recession and tracheal tug. One must just make a comment here about airway obstruction. When we think of obstruction, we generally think of a physical obstruction. And the physical obstruction is not something we're talking about in sedation. Airway obstruction is simply the collapse of the soft tissues not supported by cartilage, for example, or bony areas, and there's an area between the larynx and the pharynx that is prone to collapse upon relaxation due to the drugs that we use for airway, and therefore the airway obstruction occurs. Post-extubation stridor is usually seen after use of a tight-fitting endotracheal tube. Remember that stridor is a high-pitched sound that occurs. You hear this upon inspiration. Because subglottic region is the narrowest part of the pediatric airway, even a tube which passes the vocal cord smoothly might cause mucosal trauma and edema and significant airway obstruction. Therefore, looking carefully at the size of your airway tube is important as intubation begins to occur to ensure that we are not causing some trauma in the inferior subglottic area. Respiratory depression. The practice of extubation at deeper levels increases the incidence of tongue fallback, which is the most common cause of airway obstruction in the immediate post-op period. Laryngospasm can lead to hypoxia, bradycardia, and cardiac arrest if effective treatment is not provided promptly. Removal of the irritant stimulus, such as secretions, or maybe some water from the preparations that we're using, jaw thrust, and administration of 100% oxygen are the first steps in management. Oxygen therapy should be started with a T-piece so that continuous positive airway pressure might be initiated, which often breaks the spasm. Respiratory depression. A conscious patient whose rate of breathing is low and breathing improves on stimulation are two cardinal features of opioid overdose. If we have a conscious patient who has low breathing, oftentimes during our sedation procedure we need to perhaps rub the chest of our patients or their arm or their hands, stimulate them to remain awake a little bit and continue to take deep breaths, which will prevent this depression of our breathing. Management depends on severity of respiratory depression, if it can be reversed by naloxone or might need intubation and ventilation. A dose of 0.01 milligrams per kilogram repeated after 2 to 3 minutes is recommended, or starting off with a child who's over 20 kilos and giving them 2 milligrams of naloxone. Its half-life, however, is shorter and may need to be repeated, or an infusion set up so that the effect of the sedation drugs doesn't outlast the effect of the antagonist. Postoperative stridor is caused by post-extubation stridor, is usually seen after use of a tight-fitting endotracheal tube. Because the subglottic region is the narrowest part of the pediatric airway, even a tube which passes the vocal cords smoothly might cause submucosal trauma and edema. Racemic epinephrine, administered by nebulizer for 5 to 10 minutes, helps in reducing vasoconstriction and minimizing tissue edema. Pulmonary edema is the postoperative pulmonary edema is seen after relief of laryngospasm or airway obstruction due to any other cause. This is attributed to high negative intrathoracic pressure generated by forced inspiration against a closed glottis or blocked airway, which leads to increased interstitial negative pressure and increased capillary permeability. Once airway obstruction is relieved, the child should continue to be administered continuous positive airway pressure at 5 to 10 centimeters of water with high concentration of oxygen. Diuretics and fluid restriction is helpful. If hypoxia persists, endotracheal intubation and positive pressure ventilation with positive and expiratory pressure should be initiated. Postoperative hypotension may be due to dehydration or bleeding and can be treated by IV infusion of lactated ringers or D5W. Lowered heart rate may be due to lingering sedation, and treatment may be necessary if recovery is slow and ventilation is increasing. It's important to comment here that when postoperative hypertension may be due to dehydration, we want to ensure in our NPO orders that the child has access to clear liquids up to 2 hours prior to sedation. And it's important that we don't start sedating a child who is dehydrated already from the NPO instructions that we have given to them. The review of sedation events by Cheeker in 2012 indicated that the weight was not recorded in a third of the cases, that the lack of monitoring is a significant factor, and the drug dosage is more influential than drug choice producing adverse events. The conclusion to his study is that children that are less than 3 years of age are at greatest risk for sedation and our administration of local anesthetic. Sedation in dental offices have a high chance of occurrence where care is being conducted. Demand and need for sedation procedures has risen over the last decade. In a survey in 2001, indicated that children are less cooperative than in past years, attributing this change to parenting styles, primarily a failure of parents to set limits on children's behavior, was done in this study in 2001. Issues that also contribute to management problems includes a large number of carious lesions in low socioeconomic status patients, and the perception that children cry and struggle more readily in the dental office. The wait for general anesthesia sedation services has increased in some areas to about 1 to 2 months. Factors that increase demand for sedation. First, it is underreporting of adverse events, overreporting of adverse events with new drugs, incomplete documentation, lack of overall usage rates and changing clinical practices over time. Training for sedations is limited in some areas. Hospital OR time is becoming more limited. All these factors contribute to the increase in demand for sedations. and often, to comment here, is the unusually high expectations that parents have for sedation. There's been a study done about 3 or 4 years ago about the attitudes of parents with regards to sedation, and often any movement at all by the patient during sedation is frowned upon by parents, not understanding that we are carrying those patients at a light level of sedation. Causes of adverse events. Concern about the excessive use of opioids, more opioids than are necessary, particularly when not using weight as a guide to provide our opioid dosages, as well as obese and overweight children who should be prescribed their sedation medications based upon lean body mass. Dose-dependent increase in hypoxemia using meperidine. Increases in the use of meperidine can increase hypoxemia due to the decrease in ventilation. Use of oral transmucosal fentanyl in adverse sedation events. This is generally handled by anesthesiologists or dental anesthesiologists. The co-administration of opioids and local anesthetics and additive interaction resulting in respiratory depression. And as a rule of thumb, once drug medications are calculated and administered, do not consider the addition of further opioids or local anesthesia. Use of an opioid and other sedative drugs causing respiratory depression. Again, more than 2 drugs raises the risk level when using an opioid. And 6, deeper levels of enteral sedation induced by single or multiple doses and co-administration of local anesthetic should be avoided due to additive systemic effects. And again, calculating the maximum recommended dosages for both sedation drugs and local anesthesia. What are some precautions? Deeper levels of sedation may progress to central nervous system depression, and operators must be trained to spot these decrements. Adherence to suitable criteria discharge guidelines, avoiding premature discharge. Knowledge of drug metabolic half-life to avoid prolonged resumption to normal activities. Practiced training of doctor, assistants, and staff in the recognition of sedation levels of patients. Adverse sedation events. Respiratory obstruction. Again, obstruction is the relaxed musculature not supporting the soft tissues that are not guided by bony or cartilaginous support. Medication resulting in respiratory depression. Each drug that is being used needs to be looked at for a symbiotic or relationship with the main drug or an additive effect with the drugs and limiting those dosages. Lack of monitoring to identify lack of response, not being able to recognize the issue of shallow breathing, increased rate of breathing, increased heart rate to compensate for our lack of circulation. These are lack of monitoring and inability to recognize that we are having an emergent episode occurring. Insufficient rescue interventions, inadequate recognition and diagnosis of the problem, and that is recognition of your patient's physiologic condition going downhill and not recognizing it until it's been going on for a period, and inadequate, uncoordinated, and ineffective management of a crisis when it occurs. And that's all related to the training that we want to do. Prevention, number one, is first, and calculated dosage levels and training of our personnel, and then having everything coordinated with training to be able to handle emergency. For our concern is to be able to take care of our patient entering one of these episodes and allowing us to keep them physiologically coordinated until EMS arrives to take over. What are the recognition of signs of adverse events? First of all is the detection of respiratory rate. If the depth and rate is insufficient for the patient's physiology will help to take over and increase the rate and depth of the ventilation that's occurring. However, if it's not recognized by the clinician, it may be too late once that starts to occur. Repositioning the patient to ensure adequate ventilation is important, and supporting the respiratory rate, stopping the procedure, turning your nitrous off to 100% oxygen is really your important first step. Observation of the patient's color. The mucosa, the color of the fingernails. When you look at the fingernails, if they appear to be purplish, or looking at the mucosa appears to be not suffused with good circulation, the appearance of the lips tend to get much more deeply colored. The eyelids tend to be kind of purplish in color. Observing these sorts of things are important. If you use a dental dam in the preparation of your treatment for your patients, it's going to mask the mucosa, it's going to mask the lips, the nose. Looking at the eyelids, looking at the shallow breath that's going on should be your first clue. And if your recorder is out there, have that person mention to you, we see the pulse rate is going down, we see the EtCO2 is going up, we see the pulse oximeter is going down. Mentioning these features to you allows you to be alerted to the fact that your patient is descending into an area of inadequate ventilation and respiration. Recognition of responsiveness of the patient. Number one, to stimulation. If you're seeing that these things are starting to occur and you're turning off your nitrous oxide and using oxygen and changing the position of the head, and your respiration improves, your color improves, your heart rate decreases, your patient's physiologic parameters are going back to a kind of a neutral situation, just simply stimulating the patient, asking them to take a deep breath, asking them to open up their eyes and take deep breaths, to move their extremities and respond to your stimulation. Those are important features to let you know that the patient is alert sufficiently and perhaps has forgotten to breathe for themselves. And to verbal commands, asking them, take a deep breath, and make sure that they're continuing to do that and not just for the one time that you ask. Precordial recognition of breath sounds. Having a precordial stethoscope in the notch of the throat is an important way to listen to breath sounds. The sound of snoring or wheezing indicates you need to change position of the patient's head, maybe elevating the chin lift. Gurgling is a sound that will indicate that you have some secretions in the back part of the throat, and it's important to get back there and suction those out, or if you're using a isolite device, which is important to help relieve the secretions that are in the mouth, that's important to recognize. They may not be getting all of the secretions out, and to go in there physically and continue to suction. If one hears no sounds at all on the precordial recognition, no breath sounds, no movement at all, this means that the patient is in real trouble, and you need to be able to take action to be able to relieve this and reestablish the breath sounds that you are accustomed to hearing when you're working with your patient. Recognition of the head tilt. If the chin is touching the chest, the patient needs to be repositioned to allow good airway and intervention. Recognition of chest rise, lacing your hand on the patient's chest and feeling the heart rate and feeling the rise and fall of the chest reassures you that this is continuing to go on. Lifting the patient napkin and looking at the stomach, is that rising periodically up and down to make sure that you have continual diaphragmatic movement. Recognition of the patient's movement, of the hands moving, of the legs moving. If you're asking the patients to respond to you by giving you hand signals, it's important to make sure that their hands are visible so you can see what's going on. And the head eyelid movement, checking the reflexes by touching the eyelids and making sure that the eyebrows and stimulating that you're doing is being effective. Recognition of response to touch. When you touch the patient, does the patient move? If you go over and rub the arms, are the patients moving? Are they making any sounds? If that doesn't happen, then perhaps doing a jaw thrust and stimulating the patient with some light to heavy tactile stimulation assures you that alert, verbal or painful stimulation or unresponsive conditions are available for your patient, and periodic responses from the patient are solicited so that you ask the patient, how are you doing? Is everything okay? Are you getting tired? Can you help us out by breathing really healthy? Deep breath. All those sorts of responses are important in the recognition of where your patient is at. Recognizing the position of the patient. Are the feet pointing to the ceiling in a well-sedated child who's had nitrous oxide and or drugs? Then the feet tend to flop laterally, and if you see that, it means that the patient's quite well relaxed. Are the hands relaxed, or are they moving? If they are relaxed, maybe lifting up one of the hands and stimulating the patient, rubbing their hands or the palm of their hands, maybe something that will stimulate them to move or respond, or ask them to open their eyes. Is the head straight, or is it leaning to one side? If that's the case, the patient may be well sedated, but assessing that condition by the position of the patient is an important feature. Active dialogue with the patient is encouraged, such as, how are you doing? Are you feeling comfortable? Can you feel this? Making sure that you get some recognition. If your patient is carried at this light sedation level, you will be able to get a response from the patient by verbal stimulation. Reinforcing positive behavior. You're doing well. We are making good progress. You're doing just what we need. Those are reinforcing positive behaviors, and oftentimes when we get so concentrated on doing the procedure, we forget to positively reinforce our patient, and you can instruct your assistant to help you with this. How are you doing with that? And make sure that we keep in contact with the patient if they're light enough for us to get a verbal response. If an emergency begins to develop, your office should have the required emergency plan. And in Texas, it's required that we have an emergency plan that's written, and it tells us what each individual is going to do in case of an emergency. Let's say you're working with a patient and you have an emergency begin to develop with that patient, shallow breathing, the patient seems to be accelerating their respiratory rate, but they're having trouble in terms of depth. It's important for you to reposition this patient. But if this emergency goes beyond that, what is each of the individuals that you have there caring is going to do in case of an emergency? What is your instruction for your assistant who is helping you, their chair side? What are they going to be doing? Where is that person doing the job? Obviously, it's in the operatory, but if you need to have some assistance, it's important that you establish a code that will not alarm the patients that are in the reception area, and talk about the individual code that's going on so that when that's mentioned, everybody is attentive and everybody has a job to do. For example, if the reception area understands that an emergency is developing, their job is to ensure that all the patients that are scheduled, it's indicated to them that there may be a delay in what's going on. How often will it be performed, the job that you ask them to do? You don't want them to be out there continually saying that it's going to be a few minutes, it's going to be a few minutes. If it appears as though you need to call EMS and be ready to perform that task once you've alerted the patients in the reception area that it's going to be delayed, contact discreetly EMS and have them come immediately to a position that's occupied. For example, the back door, you have an assistant waiting there to direct the EMS team to the portion of the office where your patients are located, and patients who might be treated in other rooms with hygiene or other reasons, have them removed from the office area where treatment's being done and move them out into the reception area so we have a clear pathway for the EMS team to arrive. When will the activity that you've assigned them to terminate? They need to know how to communicate in a closed loop conversation with you all, and to be sure that they will continue to perform their task until they're told it's no longer needed. The people who are assigned to bring equipment, when will it be needed? What equipment will be needed? Well, of course, the first thing that we want is the defibrillator. Need to have that in there to assess what's going on with a heart condition. And then the emergency cart needs to be brought by with all of the information that's in there. And it's important to look and see how much the patient weighed, because all dosages are based upon what the patient's weight is and what drugs will be immediately needed to provide antagonistic reactions to the drugs that was prepared. And the dosage on the sedation sheet will be the dosage that you'll start off with and repeat every 2 to 3 minutes until the patient starts a recovery. And is all that equipment easily available? Is it near the area where you generally provide sedations? And if it is, have the drugs and equipment been checked periodically to make sure that it's current and that those instruments and all that's in there, laryngoscopes and endotracheal tubes and oropharyngeal and nasopharyngeal airways are present, that they're all there and have been recently looked at, and make sure you have no drugs that have been expired. The therapeutic solutions are an immediate response, stopping treatment, recognizing the limitations of the patient. They're having an airway problem, they're just having trouble breathing. Is their position changed? And begin to administer oxygen. Turn off the nitrous that you've been using a bag valve mask method with supplied oxygen to it will be very helpful. And to get your patient to a position where you can easily take care of them, be ready for EMS arrival, and arrive at a position where you're going to be able to help patients. So what would be some questions that would be easier to ask yourself about what's going on with these patients? So the question you might first ask is, what physiologic response is happening and what do you respond to first? And the choices are the pulse rate, color change, airway, and movement. We know from the discussions with other modules up to this point that the respiration is the major cause of any of the pediatric conditions that we typically see. Doesn't account for patients who have a medical condition, but typically with a healthy child, the airway is what has not been managed well. So what physiologic parameter do you respond to first? Well, it's going to be the airway. And the airway means we need to reposition the patient, get some oxygen going and good ventilation that's going on with our patient to make sure that we can take care of them and to be ready for the utilization of intubation to keep that airway open. We don't want this to progress to the cardiovascular system, but we want to clearly make sure that the airway and ventilation is taking place. So that's our number one priority. Number two, if you're doing a stainless steel crown on a patient or on a tooth, on a 3-year-old, let's say it's tooth number S, and you notice the patient's lips appear slightly pale, what do you do first? Do you place the crown? Do you tilt the head? Do you call 911? Do you send for help? Well, the obvious answer here is if this patient's position has resulted in slumping of the chin to the chest, then the patient has obstructed their own airway by movement or by the doctor or assistant working hard and forgetting about the position of the head. If the assistant notices the patient's lips appear slightly pale, what do you do first? Tilt the head, try to open up the airway so the patient is breathing comfortably and ventilation is taking place. The 5-year-old moves and dislodges the restoration just as you are about to cement the zirconium crown. What do you do first? Well, do you get another stainless steel crown? Do you adjust the rubber dam? Do you call 911? Or you turn off the nitrous? Well, the most important thing is to turn off the nitrous and stop the procedure. Get yourself ready. Forget about what you're trying to do to accomplish, and you may have to call 911. If you see the restoration and it's there in the throat, you have adequate access, you release very carefully and gently and accurately and see if you can't remove that dislodged restoration from the back part of the throat. If the patient should respond with a gag reflex and either aspirate or swallow, it's important at that point to cease what's going on, get in touch with EMS, and call them, make sure they get there, and you'll send the patient to the hospital if you think they've swallowed it to get a chest x-ray and see what happened with that crown or that restoration that was dislodged, and have the other patients taken care of. Go with the patient either in the ambulance, or if it's not allowed, then take your car, follow the patient over there, make sure they get a chest x-ray, because you're in charge of what goes on with this patient and you know what the history is, and you can provide that and have the rest of your patients dismissed for that time frame. Number 4 is a premature 2.5-year-old in your chair begins to cough during the prophy and stops breathing for 10 seconds. What do you do? Well, do you begin rescue breathing? Do you perform a head tilt, chin lift? Do you suction the throat? Well, first of all, they start to cough. There may be some secretions in there, so you want to perform a head tilt, chin lift, look in the back of the throat. If you see some secretions, do that suctioning of that, and begin checking, has the breathing resumed, and if it has done that, then you've cleared the problem. If you haven't cleared it, then you may have an obstruction going on. If an obstruction goes on and you appear that apnea has not been discontinued, you might want to begin rescue breathing if you can do that. If they have a physical obstruction that occurred from the treatment, you want to make sure, are they compromised by having something that they may have swallowed or aspirated? And if so, then you have to do some suctioning, which may help. If it doesn't help, then you may want to do some chest thrusts and some, if it's a small infant, it looks like a 2.5-year-old, you ought to be able to just do some abdominal thrusts to see if you can dislodge what's going on. Turn the patient's head to the side, see if you can see anything after you've tried this. If breathing ceases, you may try to do some rescue breathing, and if you do not see the chest rise, you really need to get somebody from EMS there immediately. You have a 6-year-old present for filling of tooth number E and they become intolerant of the treatment. What would you do? Well, do you start tell-show-do, or you start CPR? Do you get the mother and they become intolerant of the treatment, determine a drug to sedate the child, get the mother, start CPR? Well, if a patient simply is coming in for filling on tooth E and becomes intolerant of the preparation for the treatment, you might start with tell-show-do. This patient should understand what you're trying to do. If it looks like you're having difficulty, you might want to get the mother to see if she could help you prepare for the child, but don't start CPR unless an emergent situation occurs. And at that time, if you're still having, when the mother's back there and you can't get the child to cooperate, you might want to determine a drug to use to sedate this child. So a number of choices occur depending upon what really is happening. If the patient is simply becoming intolerant, then find a place to stop, put in a temporary restoration, have them come back when they become more tolerant. For question 6 is, you have a 4-year-old shy patient reports for sedation. In checking with the mother, she admits that she had a sandwich 2 hours ago. What should you do? Well, first of all, if they had a sandwich, you want to cancel a sedation appointment and wait for the child to come back at another time when they've observed the NPO rules. If you choose answer 8, wait until 2 hours have passed and proceed with the sedation. Well, 2 hours is not sufficient time for someone who's had something solid to eat. So it's not just clear liquids that they've had in the recent past, but it's something more than that. No, you don't do that, because you need to have at least That's a light eating episode, and so this is going to be about 6 hours you're going to have to wait. So you might want to send this patient home and reschedule. Cancel the sedation for sure. Proceed and carefully monitor. One of the things that we do know about patients who have eaten and report to the emergency room for treatment and they are sedated is that the statistics are showing that these NPO guidelines that we use may not be as rigid as we thought, but you certainly wouldn't want to risk that in your office, so you don't proceed and carefully monitor. You reschedule the patient, make sure that you schedule and emphasize NPO status before with light meal, and make sure that they are complying with that particular situation so that you don't have a further problem. The answers are listed here that you can use to check your own thoughts about this, but it's important for you to remember. What questions might we ask ourselves? Well, in the sedation of children may cause lingering effects of drugs that suppress the ability to improve muscular function. What tissues are affected through this process? And select as many as apply. Well, we know that the respiratory system is very important to what you're doing, and as we look at those tissues, it's important to ensure that the respiratory system doesn't have any muscular function that's been suppressed. And we know when we use sedative drugs like opioids, it causes the respiratory system to relax, and obstruction from unsupported soft tissues can result in decreasing the ability to ventilate. So one of your selections would be the respiratory system. The other system is the vascular system. When we have a decrease in our respiratory rate, it's going to affect the vascular system, and the vascular system may be asked to increase its constriction of its blood vessels to increase the blood pressure, and if that's not going to happen because we've suppressed that ability of the vascular system to be responsive, that would be another area. So the vascular system and the respiratory, both the kidney and the liver are influenced by the drugs that we have, but are not as critical as the vascular and respiratory system. So selecting both vascular and respiratory as tissues that are affected through this suppression by our sedative drugs, that's one of those we must pay attention to. Second, what should one do if pulmonary edema is suspected? Pulmonary edema occurs when we've had positive pressure trying to rescue a patient, for one instance, and the pulmonary edema is suspected. Then we might want to allow our respirations to work a lot better, and if we've had some infection going on in the bronchial tree, one of the ways to improve this is to administer racemic epinephrine mist. An asthmatic, for example, is a patient who typically has pulmonary edema if they have some very difficult abilities to respire and ventilate. So one would look carefully at the pulmonary edema and administer racemic epinephrine mist and some bronchodilators. Provide diphenhydramine, that's Benadryl, that's a drug that we use for allergies. Analgesics are something that we might use to control pain or discomfort, or we might want to reintubate with a smaller endotracheal tube if you notice that you have pulmonary edema occurring because of irritation and trauma to the respiratory tree. If you reintubate with a smaller endotracheal tube, that might be something that you would use if you needed to reintubate the patient to sedate them and reduce the need for a larger size pulmonary endotracheal tube and reintubate. So depending upon whether you want to continue with treatment of this patient, if you did reintubate with a smaller endotracheal tube, will allow that smaller one to go through the glottis and into the tracheal tubes to be able to help you. But if you're going to discontinue the treatment, the administration of racemic epinephrine mist would be appropriate. If you need clarification on any information, send an email to the PACE Center at uthtmc.edu so we can clarify any of the information that we've provided for you today. Here we are in the reference section, and you want to continue to use these references to come up with some of these answers that will help you in your sedation with these patients. This completes this section of the course. It's time for you to take a short exam in order to complete the requirements for streaming video courses. And once you have completed that, the nature of the subject, you need to get a passing score of 80%. It's necessary in order for you to advance to the next section. Upon a successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you'll be instructed to take the exam, and a new set of questions will be provided. You'll have 3 chances to fulfill the requirements. If you're not successful, you'll be instructed to review this section again. Good luck on the exam. If you're ready to take it, the next section, upon the completion of the exam, you'll be provided a link to continue. If you wish to proceed at a later date, you will need to log in, and no further payment is necessary since this is a continuum.